Great. All right. I think we are in our breakout room. I'm going to let others kind of come in as they choose to. I can share my screen while we're doing it. Camille, are you helping me? Oh, there's Dr. Mitchell.
Yes.
Hi, Dr. Mitchell. Okay. Can everybody see my screen? Can you guys see my screen? Thumbs up, thumbs down. Okay, great. Thank you. Okay, so I guess on the 5 after, is that what we're gonna do, Camille? Is let folks come in till 5 after?
Yeah.
Yeah,
Okay.
it's 2:03.
Okay. I didn't get to hear all of Kristen's talk, but it looked what I saw of it looked great. Like she did a wonderful job.
Also, if anyone has questions, I inserted a link in the message chat to fill out the form if you have any questions that may arise during the presentation.
Okay, from my clock, it's 2:05. So I think we'll get started so that we can end on time and allow people to have lots of questions answered if they like. I'll introduce myself and tell you a little bit about how I got involved in CCCA, and then we'll get into the talk. So I'm Dr. Amy McMichael, and I'm a professor in the Department of Dermatology at Wake Forest School of Medicine, which is in Winston-Salem, North Carolina. I'm a Philadelphia native, and I went to school for med school in Philadelphia, University of Pennsylvania. I did my residency at University of Michigan, and I've been here at Wake Forest School of Medicine for almost 30 years. And I've stayed here because it has been a supportive and amazing department to work in, and I've been able to really just do all the things that I wanted to do, including clinical work, research, and teaching. My interest in CCCA began really early on when I was a resident and also moonlighting in a very large clinic in Detroit, Michigan on the weekends. And we just were seeing so much of it, and I never saw anything about it in the books. So I said, gosh, we got to start thinking about this. But it wasn't until I actually got to Wake Forest and my then chair, Dr. Joe Urizzo, said, well, what would you like your niche to be? What would you like your research niche to be? And I hadn't given it much thought at that time, but I remembered that, we had so many unanswered questions in hair loss. So I said, I think I'll do hair loss. And he said, oh, great. Hair loss, hair and nails. And I said, oh, no, no, just hair. We're not talking about nails. I don't want to do nails. So I am a hair loss specialist, but I still see general dermatology. I love complex medical dermatology. So I see lupus and psoriasis and atopic dermatitis, acne, skin cancers, you name it. And I see it. I even do a little bit of cosmetics. So um, with that, we're going to get going on CCCA updates. And some of this is a bit technical and some of it isn't. So we'll just kind of roll with it. I'm not getting, there we go. So these are my my disclosures. I work with a number of companies for research, and anybody who's interested in hair, I'm interested in working with them. So CCCA, or central centrifugal cicatricial alopecia, can look a lot of different ways. As you can see here, it can be a very small area, it can be a very large area. And we do have patients who come in and it really is very progressed. And unfortunately, we know this as one of the scarring alopecias. We've been talking about that this afternoon. So when the hair has been attacked, we can't really wake it back up because the follicle is actually damaged. And so we think of this as a follicular or a hair follicle emergency. And so that is why we are here today, is talking about these scarring alopecias that are really truly follicular emergencies. So the point of this slide is that CCCA comes in lots of shapes and sizes. There is very little epidemiology, in other words, sort of how we understand what the population of people look like that have CCCA. There is one study from South Africa that states that around 2.7% in a group of 600 seem to have it. And that was in a study in Cape Town, South Africa. And then I myself helped to participate in or helped to do a study here in the US some years ago, 2011. And we thought about 5.6% of our population of over 500 women seem to have it. So it's not by any means a very hard and fast rule. Probably we didn't capture really the extent of it. So it's probably even higher than what we quote here. And as I stated, there's a wide range of clinical severity, a wide range of symptoms. Some people have no symptoms. Some people have severe itching, and some people have very severe pain or tenderness. And most of the people who are affected are women of African descent, ages 30 to 65, but I've certainly, and I think all of us who see this disease have seen it in men. We've seen it in people younger than this. We've seen it in people older than this. It's often accompanied by a form of hair loss called traction alopecia, and that's a form of hair loss that affects the frontal scalp and the scalp in front of the ears, and sometimes the posterior scalp just above the neck, where there's thinning that ultimately can move to become a scarring alopecia as well. Lots of people like to focus this around chemical relaxers, but this diagnosis predates chemical relaxers. It was around before people really used these widely. And so, and I've had plenty of patients who told me they've never used chemical relaxers and they do have it. So we don't think of chemical relaxers as causing this. There are some interesting recent connections out of Hopkins. Johns Hopkins is a medical center in Baltimore. And there's a researcher there named Crystal Agu who's been looking at sort of the basic science of this, trying to figure out, what is associated with CCCA. And what she found in one of her studies was that CCCA was associated with fibroid tumors. When she actually looked at it very diligently, there wasn't a one-to-one or wasn't a causal effect, but there does seem to be this idea that if you get fibrosis one place in your body, that means scarring. Perhaps you have other places where you get scars. She actually has done some specific genetic evaluations looking at what's called microarray data. She looked at 5 patients who had CCCA, and she took samples from where their CCCA was active and samples from where their CCCA was not active, and found that the scarring genes seemed to be more active or seem to be more present where the CCCA is. So she's looking at, sort of what are the controls that turn scarring on and off to try to figure out how to treat CCCA, excuse me. So there's been some really interesting work from Dr. Yolanda Lindsay and a group up in Boston. Excuse me. Unfortunately, Dr. Lindsay was supposed to join us today. She got called away for a personal matter, but she and a group of epidemiologists have been looking at something called the Black Women's Health Study. This is a very, very large study. As you can see here, started in 1995, and it follows almost 60,000 Black women, and they have a yearly, maybe a couple times a year, touch point where they send out questionnaires, and these women answer questions about their overall health. And Dr. Lindsay, who trained up in Boston, was able to add a few questions on this questionnaire. It's a very long questionnaire, probably thousands of questions to the questionnaire, and found 850 people out of the over 5,000 people had CCCA. And many of these they tracked down and they asked them, have you seen a dermatologist? Have you had a biopsy? And the majority of them had. So this was really great information. And she's sort of been looking at these data for a while. What she found when she looked at associated diseases with CCCA was not necessarily scarring things. She didn't see fibroid tumors the way the other researcher did. She actually saw an increase in type 2 diabetes in this group of patients that they have that they're questioning each year. So that was an interesting point, and we started looking for it in our own data. We haven't seen it in our data yet. And there have been other researchers. This is a Lung et al. This was a recent article published just this year, where they looked at the different things that you could potentially have. And certainly we see them a lot in people of color, including high lipids, that's your blood fats, high blood pressure, obesity, and type 2 diabetes. And they didn't actually find that the type 2 diabetes was part of something that they saw a lot of them. So I have to move us over. As you can see, the only thing that they found in this one was that the lipids seemed to be higher in this group of patients, but there wasn't more blood pressure issue. There wasn't more obesity issue. There wasn't more type 2 diabetes. So the studies are going back and forth. Right now, we can't really tell if this is really a cause that we should be worried about. Certainly, if people get diabetes, we worry about it, but we don't know that these are associations. And there are things that we're still going to have to work out about that. Now, interestingly, and this is really exciting work, there have been attempts to figure out, is this a disease that's caused by something that's happening in your own genetics, or is it something that's caused by hairstyling? And it's always been very clear to me because of the way I see family members coming in with this, that there's probably a genetic association. And Dr. Nkosi Delova, who is a dermatologist in Durban, South Africa, was thinking the same thing. And she published this very exciting information back in 2014 showing that there is a genetic predominance, autosomal dominant genetic predominance in CCCA. In other words, this is in your genetics to at least a certain extent. Now, may be something environmental that is also happening to kind of bring it out. But people who are prone to this have the genetics of just the same way other inherited diseases have. So some people have inherited, certain kinds of hair. They've inherited other diseases, sickle cell, those sorts of things. Well, this is one of those things where you seem to inherit it. So we've worked together and we actually were able to do research and obtain both blood samples as well, actually not blood samples, biopsy samples from the scalp of women with CCCA, as well as saliva. We worked with a very large team out of Israel to look at, what kind of genetics are we seeing? And we actually were able to identify this PADI3 genetic change in patients with CCCA. Unfortunately, this only accounts for about 25% of those who have CCCA, at least in our two populations. So we're doing more work now. We've actually got the information and data and genetic material from that Boston study, and we're working with the folks in Israel to try to figure out what other genetics are there. And as you can imagine, unfortunately, people in Israel are not doing great. So our study's on hold a little bit right now. But we hope to resume very soon. And we certainly wish everybody in that part of the world well right now. So we know that there's at least a genetic predisposition for this process. And so people who come in and say, gosh, I feel like I've caused this disease. What did I do wrong? They didn't cause this. This is something that was in their genetics. We haven't figured all of the genetics out, but we know that it was in their genetics, at least a good component of it. So sometimes people are not sure if they have this disease or not. They come in, they say, my scalp is itchy. My hair is breaking over this area. I'm not sure what I have. And if you look, they often have scaling. They may have a little bit of thinning out of the hair. And people who are not in the know and recognize this is an early sign of CCCA will just tell them, oh, well, you've got an itchy scalp or you've got dandruff. Here, use this medicated shampoo for a short period of time and you'll get better, or use this topical steroid for a short period of time and you'll get better. But what we know now is that when people come in with that breakage and that scaling, that itchiness over uh, uh, the crown of the scalp, it often is CCCA. And we can now do things like trichoscopy or look at it with our magnifying lights and determine if indeed it is even at an early level. So this was paper published way back in 2012, but some people still aren't aware that this is an early sign of CCCA, just having breakage and a little bit of thinning. A lot of patients will say, I got thinning and then it got thick again, and I got thinning and it got thick again, so I never saw the dermatologist. And that's a very common thing. Your hair follicles are trying to replace the hair and trying to do a good job for you, but at some point they will lose the fight if you don't treat the process, and you'll end up with more scarring. So this is a patient who's a typical patient that comes in to see me. She has got kind of a little bit of an eccentric pattern. In other words, it's not just over the middle, it's kind of going towards the left a little bit. And she's also had a scalp reduction. Somebody um, tried to minimize her hair loss by cutting out some of the scar, but they didn't actually treat her. So this is the danger of going to someone who doesn't understand this disease and getting them to do a hair transplant or scalp reduction or surgery at all. If they don't understand that the disease needs to be quiet and completely treated for the entire time of your life, then you can end up with a surgery but continued hair loss. So let's look a little closer at what we are seeing when we take pictures of her scalp. So this is a beautiful picture taken by one of my colleagues, Dr. Jorge Lavando, who is one of the co-hosts of this call. And he's a dermatologist from Chile who worked with me for a year and a half. And you can see here lots of different things. You can see irregular pigment networks, and this is with our magnifying light. You can see areas of white, gray halos around the collections of where the hairs come out of the scalp. You can see scaling that's just right around each hair follicle. And you can see hair shafts that are thin as well as some that are thick. And these are all very classic telltale signs of CCCA. Now, it doesn't mean that some of these things can't happen in others, but when you see the clinical picture, that makes sense. And then you see this and it makes sense, then you're thinking, okay, I'm in line with what CCCA looks like under dermoscopy or trichoscopy, as we call it. Now, we did some research looking to see if CCCA is just in one area because, I've seen people who have very extensive disease, and I wanted to know if we could predict that it would be other places. And what we found when we did our research, we looked at 10 women, all of whom had biopsy-proven CCCA, and we did biopsies we looked using the trichoscopy and also did some biopsies from the top of the scalp as well as the bottom of the scalp. And what we found was that even in the bottom of the scalp where you don't theoretically see changes of CCCA, there are changes of CCCA in that scalp tissue. So even though we don't have as much loss in the back, you can, and it can certainly develop into this. And that's how these patients get this. Now, we think that some people's genetics are different. Some people have genetics that just have a very mild version of this disease, and these patients have have the genetics for a very severe form of this disease. And this was first presented or talked about by Dr. Tosti and Dr. Mativa in 2015. But this on the right-hand side is a patient of mine that looks very, very similar. And unfortunately, I see this more than I would like in my clinic. So in the past, when we tried to think about treatment for CCCA, we kind of said, okay, let's at least get symptoms under control. If you have itching or pain, let's fix that. And we're still good at that. We're pretty good at that. And then we want to figure out how to explain the inflammatory and progressive nature of the disease to patients, because again, we don't want them running out and doing some crazy surgeries until everything's very well controlled. And then we wanted to minimize anything that could be potentially traumatic to the scalp. As I said before, we sometimes see this in patients who have traction hair loss. And if there is any role, and we haven't proven it yet, but if there's a role for pulling the hairs too tight in causing CCCA, we don't want to let that continue. So anything that pulls the hair tight or as painful in terms of the hairstyle you need to stop. And now in the present, we actually add a few more things. We know, as I said, that we need to rescue these hair follicles because these hair follicles are under attack. You know, this is a very acute and inflammatory attack. So we want to treat the scalp in a way that will allow us to recruit as many remaining hairs back to health as we can. So there are some hairs that have been damaged. They've been damaged permanently. We can't get them back. There are other hairs that are in various stages of being attacked. And some of them may be saying, should I stay? Should I go? And then if we can retreat aggressively, we could potentially recruit some of those hairs that we're trying to leave, recruit them back to health. And this, of course, doesn't make more hair follicles. We can't make more hair follicles, but we can improve the density of what the hair looks like. It looks fuller. It feels fuller, and we want to maintain that for a long-term improvement. So that means long-term treatment, not short-term treatment and no cure for sure. So when we treat, you know, there's a couple things that we talk about first. I always tell my patients about the genetic predisposition of this so that they can talk to their family members. You know, maybe their daughters or aunts, cousins need to go in and see about this. A lot of times people don't like to talk about their hair loss, so they don't necessarily mention it to their family. They just wear their hair in such a style that people can't tell. So we need to get the word out. Go and see a board certified dermatologist who understands your hair and your hair condition. I always tell my dermatology friends to use the dermatoscope to determine viable small hairs. I know that some hairstylists and other folks use dermatoscopes, and I've actually had patients come to me with dermatoscopic pictures, and what they've been told, unfortunately, hasn't necessarily jived with really what's happening. And the reason why you need to see a dermatologist about this and not just your hairdresser, although the hairdressers can be very helpful and supportive, is that no one is going to have the pathology understanding of a dermatologist of the scalp. Okay, they're not going to understand what they're seeing and how it relates to the inflammatory process, because that is not something that is taught in styling school. Certainly, I do a lot of biopsies in patients, particularly if they're very inflammatory or if there's a concern that they may have something else going on. We decrease all traumatic styling methods and heat behaviors to the vertex scalp or to the inflamed area. I hook everybody up with Scarring Alopecia Foundation. You guys know about it or you wouldn't be here. And there's some nice films at the Skin of Color Society. We've have films where one of my patients made a film, and with me and another faculty member, and the patients are really the star of that show, talking about their experience with CCCA. And there are several films that talk about a bunch of dermatologists talking about how we approach this condition. So check those films out. And in the inflammatory stage, we really try to get the white blood cells to go away. So we do it any way we can. Anti-dandruff shampoos, we do it with topical steroid medications. We inject steroid medications. We usually do that for series. We don't just do it once or twice. And that has been very helpful. Certain people can't tolerate that, or for whatever reason are not able to do it, or if we've gotten sort of 8 to 10 rounds and we don't see improvement, oftentimes we will do at least a short course of an oral antibiotic. And we try to push the treatment until patients are at least symptom free. And now I push it until they're free of the inflammatory changes, like those scaling areas, those red areas that I showed you on a very close-up picture. And then after the inflammation's under control, people don't have symptoms, they're not itchy, not tender, we start, sort of just spacing out their topical steroids, but continue them. We also add oral and topical minoxidil to prolong the growth phase of the hairs. So if these hairs are very fine, I showed you very tiny hairs, and we can keep them on the head longer, then they'll thicken up and become hairs that are fuller and denser and make the scalp look better. And topical and oral minoxidil can do that. And you have to check with your doctor to find out if you're the right person for those treatments. And then we can also do surgical restoration. And a number of people are now learning how to do surgical restoration that is really, really good in people of color. It's a little trick to it. Not everybody can do it. And again, it has to be done at the right time in the course of your treatment. But this is an option, a little bit expensive, not covered by insurance, but it can be very helpful. We also use 5-alpha reductase inhibitors. Those are things like finasteride, dutasteride, and maybe they work probably because there's underlying female pattern hair loss. We're not sure, but it can be helpful. And then I'll talk a little bit about some emergent therapies. So just remember, when we talk about follicular rescue, when there's scale and redness, the disease is active. When there's significant loss of follicular openings, and like the picture you see on the right, then oftentimes this disease is burnt out and we're not going to necessarily make more hair or allow the hair to even thicken up enough to really contribute to density. So we want to really attack the inflammation early, and do anything we can to take down the inflammation and then build up, recruit, and regrow the hairs that are there as best we can. But of course, we're not talking about turning back the hands of time to where there was no hair loss at all. So this is a evidence of how treatment can work. This is one of my patients before and after treatment. She was wearing a chemical relaxer. She decided to go natural, and that helps the appearance of density as well as helped her not have to do so much to her hair. She used injection steroids and topical steroids, and really did have a very nice outcome. And this is kind of an average response. Here's another older woman who was having injections as well as topical steroid, and she also did topical minoxidil foam once a day. And as you can see, she did have some improvement. And again, we're not regrowing hairs that weren't there. We're taking down the inflammation so hairs can grow, and we're prolonging the time that they stay on your head so that it thickens up and gives contribution to density. So sometimes you can have a good response. This is one of my patients who came in with pretty significant CCCA. We talked about good hair care. She did what I said. She did treatments, and then she put on a hair weave or that was glued to her scalp. So she would leave it in place for 3 months, take it out and wash her hair and reapply it. So during that time, she wasn't washing her scalp. She was using glue, which when it was removed was pulling her hair. And this is what she looked like. So she was worse off than when she came to see me in the first place. So when you grow hair back in, when hair regrowth occurs, you're lucky enough to have that. You need to treat it like your best wool sweater. Okay. You wouldn't take your best wool sweater and put glue all over it and never clean it and, treat it as if it were, something that was going to always be there. When you have hair, you need to treat it very gently. No pulling, no tugging, no glues. Washing regularly my contract with my patients is every 2 weeks at least. So this is very important. When hair regrowth occurs, it's not always durable or lasting. Sometimes patients will color their hair. That can give you sort of like a camouflage look and make it look less noticeable. She underwent medical therapy, injections, topical medications, and she got some nice density. But she wanted to go a little bit further, so she went and had surgical restoration with a colleague of mine and did very, very well. So she's very happy. Now, what about other things? So we did a study looking at low-level laser light. This is actually a light that is an LED, to be honest. And it's really out there. There are lots of them out there on the internet, and I can't speak to all of them. The one that we used is Revyon, and I have to say that's a disclosure because they do give us the caps to give to the patients. They don't give us any money. They don't give me any money, but they do give us the caps. And so the Revyon cap, which is an LED, dual wavelength, orange and red light, did seem to help a group of our patients. We did a sort of a pre-study of 5 patients. One of them was lost to follow-up. The other 4 continued, and many of them had improved symptoms, as well as you can see several had improvement in growth. So very nice. It doesn't mean it's going to happen in everybody who tries it. These are also very expensive. So maybe it doesn't fit in the budget, but as far as I can tell you, this particular one did. Now, does every single one work the same way? No. Does the one at Costco work like this? I don't know. So I can't say, but you can certainly look up the Revyon red light and see if you want to look at that. There is some work done by Dr. Agu again, looking at platelet-rich plasma, which is where we draw your blood, spin it down, take the top layer, which is the plasma layer, has the activated platelets and growth factors in it, and inject it back into the scalp. This is also not covered by insurance, and it is a bit painful, so there's that to consider. But Dr. Agu showed in a couple of patients that it could be helpful, even in those who didn't respond to regular treatment. We looked at our population of patients, and we published this as well. Dr. Lorando is the lead author on this one. And you can see that after first session, third session, fourth session, these patients did seem to get better, but when they took a big long chunk of time, after 6-month intervals, they started losing again. So again, if you're doing topical therapies at home, those need to continue. And you probably need to have a little shorter interval between PRP treatments, maybe no more than 3 months, which makes it more expensive, of course. But at least you don't want to lose that gained hair. So you have to continue doing it if you're going to do this treatment. And this is, going to someone again who knows what they're doing. Dr. Agu also published this short case, two cases of CCCA that seemed to fail standard treatment and responded to 10% topical metformin. Metformin is a drug that we use for diabetes control, but she put it topically so it doesn't absorb into the body. We don't know exactly why her patients got better. I've had patients, tell me they want to try it, and I've tried it in them, and I've never seen this effect. I've not one time, probably in about 8 times, maybe 6 times of doing it, seen improvement. So in my hands, this doesn't work. I wish it worked as well as it seemed to for Dr. Agu, but even when you talk with her, she tells you it doesn't work in everybody. And then if you look at before and after patients, and we're going to wrap up so you can ask questions here in about 2 seconds. We looked at our patients before and after, just a small study actually of 15 patients, how many people are really getting better. Well, we show here that there about half of the people worsened, and about a little less than half the people either stabilized, which is good, or had decreased severity. In other words, they got better. What we didn't standardize for is how much of everything they were doing at home. So some people may be very diligent about putting their medications on, and taking their oral medications. Others may not. So we don't have any way to show what they did, but just in general, offhand, we found that people did better if they, when we looked at them, at least half of the people did better. So it's worth treatment. We saw that factors affecting the severity seem to be the time that people had the disease. So the longer you have it, the worse you're doing. And so that means that you need to come in early, right? You need to come in early. We looked at a group of 100 women more recently. This is, again, another paper with Dr. Lorando and one of my then students, now research fellows. She's a research fellow in a place in Ohio. And we saw that average age was around 50. We also saw that at least 70% of the patients coming in had symptoms: itching, burning, stinging, something. And we also saw that there were about 48% of people who had no findings other than just the hair loss. They didn't have pustules, they didn't have scaling, no redness. And so what does that mean exactly? I'm not sure. But what we do know is that some people are, kind of come in and they're already burnt out. We're going to have a little harder time treating that group of patients. And we looked at things that predicted improvement in this group. And when we saw what helped people get stable disease, in other words, they didn't worsen over time, over usually a year or more, we didn't understand this, but the fact they had a history of thyroid disease. So it might be that they were taking thyroid medicine and it actually helped them control things, as opposed to if they had thyroid disease and they weren't taking their medicine. People who used a hooded dryer as opposed to a handheld dryer seemed to do better, and people who had natural hair. Not saying that you have to have natural hair, but that's just what we saw. In improved disease, People who use oral metformin, so this gets back to that metformin story that Dr. Agu was saying, people who had diabetes and were using oral metformin for their diabetes seem to have more likelihood of getting better. Again, the hooded dryer. So we're thinking maybe people are using hooded dryers instead of manipulating their hair with a hand dryer or air drying. I'm not sure. History of natural hair again, no history of thyroid disease. So if you don't have any thyroid disease, that actually was good for you. And hair loss is the sole clinical finding. So people who came in and didn't have a lot of itching, burning, stinging, and other things on exam. And so, why am I saying all this about treatment and trying to understand treatment effect is because if we don't treat, we know that people get worse. So, this is one of my patients, lovely lady, came in. We diagnosed her with CCCA. She had a biopsy and everything. We told her all the things that she needed to do, and she went home and she did absolutely nothing. She came in a couple of years later and she was appalled to find how much hair she had lost. She knew she had lost some, but she didn't have a picture like we did. And so this is not the story that we want to be able to tell. We want to tell the story of people getting better or at least stabilizing. So in summary, I always tell all my folks use dermatoscopes so that you can get in and see early disease. Discuss the genetics. I discuss it with my patients to make sure family members understand that this may be an experience that they're going to have and to come in sooner rather than later. Manage any kind of traction or tension kind of hair care practices and aggressively treat for the inflammation. Remember, staff is there to help you. And in post-inflammatory stages, after the inflammation is down, you could certainly use things to help maintain that hair and potentially keep the hair on your head longer. And I like to tell my patients the story of follicular rescue. In other words, we're going to rescue those hairs for this condition. And I'm sure that now that you know about follicular rescue, you'll join in the fight. So I'm going to thank you for your time and for listening. This is my team, Dr. Jorge Larondo. We write together. We studied all these diseases together. And Dr. Ivy Obami, who's my research fellow this year, she's applying to dermatology. So thank you for your attention. And I will stop sharing. And we can move to the question portion of this afternoon.
All right, thank you for your presentation. I guess we could start with the questions that were submitted through the form. The first question was, what do you think about low-level laser therapy?
Well, good question. I'll say what I think, and Dr. Mitchell can say if she has any experience. So you saw our study. We think that it's a great way to sort of have an adjunctive treatment. I would not say to someone coming into my office, okay, this is all you need. Just try this alone. I think that it's an add-on therapy in addition to topical medications, maybe even oral medications. So that's what I would say.
I agree. It's part of a multifactorial approach in my office as well. So
Mm-hmm. I see some things in the chat. One says, I've seen several dermatologists for CCCA and none have used a dermatoscope. Is this a tool to use to measure hair loss? Yes, it is. And, it's, people who are not specialists in dermatology and hair loss don't always use it. If you have biopsy proven CCCA or that that's what your disease is, perhaps it's not as important, but I like to use it because um, I like to see where you are, how inflamed you are. How are we going to attack this? Are we going to basically just keep hairs on your head? Are we going to take down inflammation? Like, where are we in this fight? So I like to use it. I'm not going to say that people who aren't using it aren't good. They just maybe haven't adopted the practice. People use it for moles and that sort of thing. I don't use it for moles. So somebody might say that's bad because I don't use it for moles. But so I think it's really, what you can do and to help, I think. But I'm not going to say that because you've seen dermatologists who haven't, that they haven't given you the right treatment.
All right, so next question was, I'm only wearing ponytails or topics to disguise the loss. Is this considered a tight hairstyle?
Dr. Mitchell?
I am a fan of switching up the hairstyles, and it just depends on how that ponytail is being pulled. I think it's important to take the hair down and to take care of the hair. So cleansing is important, conditioning, being able to apply your products to your scalp. As Dr. McMichael said, we're trying to rescue hairs. And so a lot of times, as part of your treatment plan, we're going to want you to apply medications to the scalp each day. So I think it's important to be able to have that styling where you can get your medications to the scalp. You want to make sure that the ponytail, they can be tight. The ponytail can pull back on areas that have more hair loss. And so you want to make sure that you're not doing that as well. But I think it's really important to mix up the hairstyles.
Yeah, one of my friends, I think it was Dr. Candace Heath. She's a dermatologist who sees pediatric and adult patients. I think this was her said, when you put in a hairstyle, the tightness of it should be whatever it would have been at 2 weeks with the hairstyle in place for 2 weeks. She was mainly talking about braids and twists and those sorts of things. Because if you put in a style and you say, "Oh, it doesn't hurt," it doesn't hurt, and I don't have those pictures in this particular presentation, but you can see at the base of the hairs are screaming, they're red, there's pustules, there's hair casts, there's a lot of changes. So when you put in styles that are tight, make sure that they feel like they would feel at the end of 2 weeks so that you're not pulling on anything. Because even if you don't have pain, your scalp is registering something going on and it's saying, okay, well, you can pull all you want, I'll give up. I'll absolutely give up. And you don't want your hair to give up.
Mm-mm. Or to bring in inflammatory cells, right? To try to rescue a problem and then cause more hair loss.
Right. Oh,
Right, next question was, does topics interfere with scalp treatments?
Does
Topics. I believe it's some.
Yeah, it's a little fibers. Yeah, I don't think so. I think you can use it easily. It's great. Yeah, it's very nice. There's lots of different ways you can camouflage with the different topical things. There's topics, there's some other things, and it's absolutely fine. Again, you need to cleanse your scalp, at least every couple of weeks. So you don't want to leave it on there and just keep putting more and more on there, potentially because you have to use your topical medication too. But yes, topics is absolutely fine.
Mhm. Yeah, a lot of my patients use hair fibers as well. I'm not quite familiar with that brand, but they work really well.
How can I find toppers for African American women?
Good question. It depends on where you are and what your price range is, So I actually often tell patients to look in their local area to see what's available. Go to the beauty supply places that have a lot of different kinds of things. There's some of them allow you to try them, some of them don't allow you to try them, some of them allow you to try three, so you'll have to play around with that a little bit, but at least you can get an idea of what looks good on you and what feels good and what doesn't look cheap and kind of the styles that you like. And you can also see things at different price points that way. You don't have to necessarily get them there. Once you figure out what you like, you can order them online. I also tell people to go to the National Alopecia Areata Foundation marketplace. That's online. And they have a lot of companies that sell different kinds of toppers, and some of them are there for people of color. Just depends on what you like. The other thing you can do is consult with your stylist. If you have a stylist that's in the know, they can direct you to places where you can get nice hair pieces. But it really does depend on the area of the country you're in and how much is available where you are as to whether you can get it locally or you have to go online.
What treatment can be done after the burnout of CCCA?
Well, I know Dr. McMichael will have an even better answer, but we don't want to get to the burnout. Is definitely important. And it's really important to be seen early, right? As soon as you are experiencing hair loss. We also tell our patients, just symptoms that you can't explain in the scalp, right? Itching and burning. Even if you don't see the hair loss, it's important to come in and be evaluated, because I tend to use my dermatoscope a lot in those cases where, things are not very obvious to try to get additional information to be able to help my patients. And so you can't come in to be evaluated for hair loss too early. We love giving good news, and if we're just going to give you good news, it's just good to be able to do that. If we see something that we think can be a problem, we're going to educate you about that as well. And we're detectives. We're very good history takers, and we're not just going to possibly stay with you. We're going to ask about family history, etc. And so we're going to give you things to think about as you continue along. Even though today things may look good, we're going to give you advice and information to help you in the journey. And so I think it's really important. That having been said, burnout is kind of end stage. And so this is a condition that can be chronic, it's inflammatory, and there is no way to cure it. And so in our eyes, burnout can be end stage and difficult to really bring back those hairs.
I would agree with that. I think we don't have a lot of treatments that are available for that, because we can't necessarily revive those hairs. Now, that's when potentially you could think about doing hair restoration if you have enough donor hair and you have somebody in your area who can do it, and you have the benefit of having enough money to do it. Those sorts of procedures cost upwards of $8,000-$10,000. And even much more depending on where you live. So so there is that, but only for those people who have donor hairs to give, because we're not using hairs from other people, we're using your own hair. So you have to have a full back scalp, a number of hairs to really help with that. And that's really the thing, that you can do. You can't cut all of this out, because you wouldn't have enough scalp to cut out. You wouldn't have enough scalp left if you cut a lot of scalp out. So really, we want to get, as Dr. Mitchell said, we want to get you before that happens. We don't want any kind of burnout. I'll take another one that I see. A couple of people have asked about supplements. I specifically left this off because people put a lot of weight in supplements, for their overall health. I think you can't ever replace having a good and healthy diet with supplements. Okay. So that's the first thing. I have people that come in and they're eating crazy stuff, and everybody's always starting their diet on Monday. Okay. That's great. But what you need to do is you need to get yourself and your overall health in good shape. Now, is that going to have a direct effect on your hair and cause hair growth? No, but it's going to play a role. So in my mind, you need to have get out those high sugar things that you're doing, drinks, foods, etc. Good healthy protein, good healthy vegetables, good healthy fruit, and try to focus on that for your meals. And then if you want to take one of the supplements, there are no such things as vitamins for hair. I know that people see them on the shelves and online. There's no vitamin for hair. There's no such thing as that. There are supplements that are sold for hair. And what they do is they just sort of make your scalp healthier. They don't grow hair. They don't, change your hair disease. They just maybe make your scalp a little healthier. I have not seen a super significant benefit in scarring alopecia, but I have not done a study per se in this disease. I think that they can be much more helpful in non-scarring forms of hair loss. But again, they're not a replacement for a healthy diet by any means.
All right. So next question was, can you please give your opinions for scalp micropigmentation? What do I need to consider in terms of risk, finding a qualified practitioner?
I don't do it in my office, Dr. McMichael.
No, me either. Because there's just so many things you can't do. We try to do what we can. We do PRP, but we have referred people to local places. There are many, many places popping up, and I think it's just like everything else. You have to go and you can look at their business and see what their feedback has been from the clients that they've seen. You can go evaluate them, talk to them, see what they know about your potential, your specific form of hair loss. asked to see before and after pictures. There's no standardization that I'm aware of that's going to tell you whether they're good or not. So I just, look who's in the area and sort of tell them those caveats and hope that, they can find somebody really good. I have people that I know that do it. Unfortunately, they don't live near me. So for my patients to go there, it'd be impossible.
Right. How can you tell if your scalp is still inflamed? I use a topical and also get shots every 6 weeks.
Yeah. So I think the things that we use are your symptoms. So if you were itchy and now you're not, that might mean that your inflammation is gone or your scalp's no longer tender or painful. So that might mean that. But I'd say have people that, their itching and pain is gone, but they still have a little bit of inflammation. Again, that's where we look at our dermatoscope to help us. What are we seeing close up when we look down there? I'm not a fan of doing every 6 week injections forever. I think that that's a good way to approach it. Maybe do, like I said, somewhere around 8 to 10. And I might even do a rescue one if people sort of leave me and stop treatments and then come back and they're very inflamed. But I don't think that this is like a 2, 3 year thing. I think you need to figure out something else to do. People have remained inflamed for that long after injection. So it's got to be a conversation with you and your dermatologist. I know a lot of people see physician assistants, for instance, or nurse practitioners, and they are not always trained to use a dermatoscope in their training. Depends on who trains them and what they're familiar with. So you need to ask, do you have training to look at this under dermatoscope? And if not, can I see the physician, who is managing you at least one time and see if they can do it? And if not, then you need to find somebody who can.
And I also use, in addition to what Dr. McMichael said, photographs, right? And so we do AI checks. Sometimes that can help, just looking for advancement of the condition, because we don't always have to see signs of inflammation, but if the condition is worsening, there may be a concern that the condition is worsening. I don't know if I said that correctly, but we don't always have to have inflammation or symptoms to see that the condition is expanding or worsening.
That's right. And this is one of those insidious diseases. Before I used my dermatoscope, which really I literally just started using like in the last 5 years, um, I would just look at people and say, well, they don't look inflamed, because there are certain things that we see in our office, psoriasis, eczema, where people are red and they're scaly and all this stuff. And we'll look at people's scalp and think, doesn't look bad. So if you're just looking with your eyes, in a one-time situation, you may think, oh yeah, no, it's fine. So that's where the pictures and the dermatoscope come in.
Mhm.
All right, next question was, I had a hair transplant prior to my diagnosis of CCCA. The donor area in the area where I seem to have developed CCCA. I have been treating with success. My dermatologist said I came in early and that's what saved me. What are your thoughts?
Well, the first thought that I had was, it's always best to have a diagnosis before we invest money into cosmetic procedures, right? Because a lot of there are multiple causes of hair loss, and a lot of the conditions can wax and wane, or be chronic. And so you don't want to kind of put the cart before the horse and do a cosmetic procedure like PRP, like transplant, like hair lasers, etc., without knowing exactly what type of hair loss you have. And it could be more than one type, right? And so it's really important, as with anything in life, to get the foundational things under control first, right? So those foundational principles, understand them, understand, as Dr. McMichael said, what are we doing in between our treatments, right? There's always going to be a foundation that keeps us set and steady. And so the best thing to do is know what you have first and get a plan, understand how you keep that problem or that form of hair loss under control before. And I think, if I'm hearing it correctly, there may have been an ability to decrease or reduce inflammation so that there was not a rejection of the transplant, but that's not the way that we want to operate.
Agreed. I think that's very well said. I would agree with that. I think somebody wrote in, I think they were asking that they are saying they were told that CCA patients are not candidates for transplant. And that was true for a lot of, and may still be true for a lot of people who do scalp restoration. So not everyone is going to do this for this condition. But over the last, I'd say 5 to 10 years, people who do hair transplants have gotten better at them. They've just gotten better and better over the years. And people who want to expand their practice have started to learn how to do larger grafts, which are usually required in people of color who have curly hair. They've been, making sure that there's not active disease before they start doing them. Now, that's not true for everybody. You can go to Tom, Dick, and Harry and they're just there for the money and they'll do your transplant, like Dr. Mitchell said, before they even know what you have. They're not even dermatologists. They may be people who are surgeons of other types. They're burned out in their field. Even some ER doctors, OBGYNs go into this hair transplant business. And so they are not dermatologists and they're certainly not board certified in dermatology. So you want to see a board certified dermatologist if you're going to get a transplant for scarring alopecia. That's just bottom line. You want somebody who knows what they're doing and has done before and has good outcome. And so, that you can certainly get them. You have to find the right person and you got to make sure that they know what they're doing.
Dr. McMichael, how long do you like the CCCA to be stable before you would allow your patient to even get a consultation or consider hair transplant?
I usually have people wait about a year, at least, stable for 1 year. Some transplant folks will say I have to have 2 years, and that's what they require. So that's okay, that's them. But I usually tell people you can start to look into it at a year.
Me too. 1 to 2 years is what I've heard as well.
Mm-hmm.
Someone just asked, can follicular units be transplanted into scarred ostia or only in rescued follicles?
So the transplants are not placed into the actual follicular openings. A lot of times the follicular openings aren't even there. That's what we call it follicular, loss or occlusion. So what happens is you take these, viable hairs with the skin attached to them from the back of the scalp, usually in a strip. And then these are cut up into like 1 or 2 or 3 hair units with the skin attached. And then you make openings in the scalp and these hairs are stuffed into those little openings. You use a little tiny knife and it's just a little slit and you stuff them in there and they stay in there. You don't have to have, stitches or anything. So you're not placing individual hairs into a hair follicle. That's impossible to do. You have to have the hair with its accompanying skin and a little bit of the tissue below the first level, upper levels of skin in order for the hair to stay. So it has some blood vessels and all that. And then you put it into the scalp, and it is a miraculous thing. It doesn't mean that the hairs around it won't be affected, but you can put it right into those little slits that you make. So it's not a one-for-one kind of hair to hair follicle kind of process.
When using your topical steroid and minoxidil compound, which do you suggest applying first?
Well, we can prescribe them separately, right? And so today we can prescribe a topical minoxidil product, and many of you may know Rogaine to be 5% minoxidil, which you can buy at Costco, probably Sam's Club, lots of different drugstores. But when you see the dermatologist, we now can prescribe minoxidil at a higher strength. And so we may do 7, 10, even upwards to 12%. And so sometimes we will prescribe that separate to a topical steroid, or sometimes we can mix it together. Personally, when I'm treating maybe androgenetic alopecia or female pattern thinning, I may not use a steroid because there may not be much inflammation there to chase. And so we may decide to prescribe that by itself, so minoxidil alone. But when we're treating an inflammatory process like CCCA, we can use a compounding pharmacy that can put both products into one jar. And a lot of times that makes it a lot easier. for us. Or I suppose you could layer the products, right? And I tend to have them compounded and mixed together. Dr. McMichael?
Yeah, I have done some compounding. I probably do less than most people, and I just have people put them on different times of the day. So for my steroids, especially when you're in maintenance phase, I don't have to do it every day. I do like the minoxidil topical to be daily if possible. And then we've also moved to a lot of oral minoxidil. So, some people are not using minoxidil topically, they're taking it orally. So that again is something that you have to talk to your doctors about. I'm just looking at the time, Camille, it's 3:03. What's our plan? I don't want to hold folks if they're supposed to be going back to doing something else, but I'm happy to stay another 5 or 10 minutes if need be.
Yeah, I believe the general session begins at 3:30, but I can confirm.
Okay, all right. So when you tell us, I'll stop talking. So I'll look and see while you're chatting or checking. I'll look and see. It says, how long do you recommend being on antibiotics? Can you help those of us who may be concerned about side effects to understand the benefits? Dr. Mitchell, do you want to
Sure.
grab that one?
So with antibiotics, we tend to use the tetracycline family or doxycycline, and we're using them mainly to help control the inflammatory process that is trying to really take out the hair follicles and replace those follicles with a scar, right? And so, unfortunately, there are things that may happen that are out of your control, stress, family emergencies, etc., that may keep that inflammatory process going. And so I know when I start out, especially if I see more advanced CCCAs, especially when they're symptomatic, we may go at least 3 months and then reevaluate. I find that with chronic inflammatory conditions, while we may not want to go many, many, many months long term, we may be in and out of them. So we may be able to use them for a while, take a break, and then, if the inflammatory process picks back up, or if the condition seems to be worsening, then we may opt to restart them. So our goal is not to keep anyone on antibiotics longer than they need to, but if you're having the symptoms, it's one of the signs that the process may be expanding and the condition may expand. And we don't want to go from something like this to something like this. And so I think we customize that treatment plan to our patients. We're very vocal about helping you to understand what could be an issue in terms of that inflammation, itching, burning, that crawly feeling, that etc., that may warrant being on that treatment. So while you may come off and you may do well, if that starts back up, we may want you to start that, get back within us, and to see us very quickly. So long story short, we do customize oral antibiotics to our patients.
Agreed. I don't have a thing to add to that. I did see another question in there about Illumiant and whether or not I use that in my patients. In my clinic, we do not have samples of Illumiant. We have to apply to the pharmacy because we have in-house dermatology pharmacists in our department, but we can't we have to apply to the big pharmacy of our hospital in order to keep samples, and we have to show that we absolutely need to have them, and they have not approved Illumiant samples. So I don't even give samples out of Illumiant, period, even for the FDA approved use, which is alopecia areata. Now, so that means that if I get the Illumiant, it's going to have to be on the FDA approved use because no insurance is approving it for people unless they have alopecia areata. So I either have to lie or be mistaken. And I'm usually not a liar. So I don't do that. I'm too ethical for that. And I try not to be mistaken. So in my hands, unless you have alopecia areata along with your CCCA, you are not going to get Illumiant in my practice. Now, what do I know about Illumiant in terms, or baricitinib, if other people know it by that name? So it was the first drug to be approved for alopecia areata by the FDA. And there is data, it's not published yet for as far as I know, but there's data by a researcher at Mount Sinai, um, looking at using this in early, very early, still hair follicles, hair able to grow, follicular units are intact, but maybe mild disease, and early CCCA with some good improvement. And I have other people who've gotten it for their patients various sundry ways. I don't ask. And they have seen some improvement. And it's an anti-inflammatory drug that works on a particular immunologic system that is the gateway for a lot of inflammation. So these drugs have been used for rheumatoid arthritis, psoriasis, atopic dermatitis, alopecia areata, um, ulcerative colitis. So they are great anti-inflammatories. So it doesn't surprise me that this is going to work for an inflammatory condition like CCCA. However, you do need to temper that with the fact that these drugs do have to be monitored with laboratory tests. People don't like that. You know, you have to look at your blood fat, your lipids, you have to look at your liver function, you have to make sure you don't have TB or hepatitis, look at your white blood cell count, your red blood cell count. So these are not drugs that we just throw at people and say, okay, have at it. You know, we have to monitor them. So you have to sort of make sure that you're doing the right thing in the right patient. So I'm very careful about that, and I won't prescribe it for somebody. I wouldn't give it to me if not if I had a sample until I see some data or I do a study myself. And so I haven't done either one of those things. So I am personally not using it.
Oh, so I just want to let you know we have until 3:30.
Ah, okay, cool.
I'm not sure if you answered this question, but what resource can we use to access doctors that specialize in CCCA in our own areas or across the country for us that relocate periodically?
Well, you definitely can. There are lots of resources. I'm sure we can tag each other. AAD is a resource, the American Academy of Dermatology, and you can seek out dermatologists in your area, and so that's one resource. Another resource can be Skin of Color Society, where you can find a dermatologist as well. You can kind of Google, I'm sure that there's some information online. A third resource is blackdermdirectory.com. And that's a directory where you can put in the area code that you live in, and doctors will come up. And you still have to do your research, right? Like you still have to, vet doctors. It's not that we're not all trained to take care of hair loss, but there may be some dermatologists that are more passionate, like Dr. McMichael, about hair loss. And so I think it's pretty easy nowadays to kind of get more information about dermatologists in terms of what they really specialize in. And in all fairness, what they have a passion for, excuse me.
Agree.
What are your thoughts on hydroxychloroquine?
I sometimes use this, so I've been on and off with my use of it in CCCA. So I'll tell you when I use it. I use it when I've done a biopsy and the biopsy results are something that suggests, yes, it looks like CCCA, but then a part of it looks like another scarring form of hair loss called lichen planopilaris. Or if people have a ton of inflammation and I really don't want to continue them on antibiotics or they're having a side effect from an antibiotic, and so I need to do something else. So I will use hydroxychloroquine, or the other name for it is Plaquenil. And that's a long-term medicine, you know, so I don't feel bad about doing that. We do also have to monitor that. You have to have eye exams yearly, and you also have laboratory tests every 6 months. But that's much simpler, and it's an older medicine. We're very familiar with it. So do I think it makes a huge difference? You know, like I put people on it and they're amazingly clear. No, but I think it does have a role in CCCA for some people.
And I think it definitely covers one of the areas that you talked about is halting the progression, right?
Mhm.
And so I think we agree as dermatologists, it's a win also when we can halt the progression of a chronic progressive condition.
All right, next question is, will I have to take medication daily, like spironolactone, for the rest of my life to retain hair growth?
I think it depends on the diagnosis, right? It depends on why we're treating. I just saw a patient with PCOS and hair thinning, and I started, just kind of an aside, that medication. And so there are a lot of factors that go into that condition. And depending upon, how the patient does in all of those areas, right, will kind of help us to be able to wean some of the medications. It's no different than diabetes and hypertension, right? If we are able to do better in other ways, then we may be able to wean medications.
Agree.
Is there a cure? Do you see that there will be a cure for CCCA in the foreseeable future?
Wow, that would be
Awesome.
great. I know. I'll tell you what, if we could get that, I would definitely probably retire. I'd be like, okay, I'm done. That would be a drop the
Your
mic
work would be
moment.
done.
That's right.
Your hard work would be done.
Yeah, I don't know if my hard work will have anything to do with it, but it would definitely put me in a better situation. No, I don't know. I mean, I would love to hope in our lifetime that's going to happen. Scarring alopecia is very complicated. I'm sure that there is more to it than just an inflammatory process. And, the genetics we can't change, right? We know that there's a genetic component, so we can't change how you're made. But we might be able to get it to the point where, once we have a test for it. Like you can test people and say, you have a gene for this. So you'd have to make sure that when you're doing your hair for the rest of your life, you do very gentle things, that sort of thing. So that might come before a cure, is what I'm thinking.
Love it.
Are there any holistic methods for hair regrowth, controlling scalp discomfort and inflammation?
Well, I think, rosemary oil, I mean, I think that we have seen some efficacy there, but I think equal to maybe a very low dose of minoxidil. So I don't think of anything as being a better treatment option than the medical options that we have right now. So maybe it's, adjunct to what we're doing, especially if it provides hydration to your hair, or you feel as though there's an enhancement of the health of your hair. I think that those can be considered, but I haven't seen anything that I would consider to be more beneficial than the treatment options that we have studies for.
I would agree. I really do feel though that and I've said this already, but it bears saying again, I think is to get your lifestyle as healthy as possible, and that means, looking at what you're using to fuel your body. Are you using things that have a lot of nutritional value to fuel your body, or are you using things that, are quick to grab because your lifestyle is so busy? I think it warrants you to slow down and really think about, okay, what is the fuel that I'm putting in my body, because that makes everything better. I mean, that just hands down, your overall health is just better if you get the appropriate amount of vegetables and good proteins and that sort of thing. So I can't say enough about that. Is there a dramatic difference in CCCA per se? No, but your overall health will be better. So I would recommend that, get adequate exercise, get adequate sleep. These are all very difficult things to get, I think, for a lot of people. So I think if you can attain or move towards attaining those things, that will be very helpful. And I think that, it's harder to get those things than it is to go buy a supplement. So people like to just go buy a supplement, but I think you need to work towards the other things. And that takes a lot of work, and it takes a lot of support from other people, because a lot of people, in my experience, I don't know what you all's experience is, but in my experience, many of the women that I see with this, they're heads of their household. They have a lot of responsibilities, and as a result, they maybe put themselves last a lot of the time. And so you have to put yourself a little bit more first, I think, to get yourself healthy. So that to me is the holistic way to get your life and your health together. As opposed to sort of going and getting a supplement off the shelf. If there was one, we would certainly tell you about it, but I don't think there is. Another thing that I tell people, a lot of times people tell me, oh, I use coconut oil and I use jojoba oil and I put avocado in, and I have a friend from Mexico, and he would tell me, he said, yes, my patients all want to put salad ingredients on their hair. Why do they want to do that? I don't know why people want to do it, but it sounds healthy, right? Salad is better eaten, absorbed into your GI tract rather than put on top. So I don't think most of the things that you throw on your scalp actually get absorbed. And if they sometimes they actually prohibit the topical medicines from working. So I would be very careful about putting topical things on that are so-called natural. And then Hope has probably heard me say this before too. Dr. Mitchell is probably tired of me saying this, but everything that is natural is not good for you. So, like snakes and tigers will kill you, and they are natural. So, natural is not always good.
Right.
Do we think healthcare providers will ever will cover the cost of wig prosthetics for women with CCCA?
You can get that right now. I write prescriptions for my patients, and a lot of insurances pay for it. You just need to get a prescription and a letter and keep it rolling. Absolutely, you need to work on that. And if your insurance doesn't give it to you, you need to appeal. I mean, you can make this happen.
Are there any recent research advancements that have been made in CCCA?
Well, yeah, I mean, I think we went over most of those. We know about the genetics, we're looking into um, the, the links to other diseases that are fibrosis-like diseases like fibroids. We're looking to see if maybe there's a link to diabetes, obesity, hyperlipidemia. We're looking at treatment options, where metformin may play a role. Yeah, I mean, there's lots coming out. It's to me, it's amazing because I'm in this business now 30 years, and when I started, there was none of this. So I'm excited that, a lot of young people, well, I'm old, but older and young people are excited about looking into this disease and ways that we can slow the progress, and also, turn the tide on the inflammation.
I believe someone in the chat wanted like clarification. Is it minoxidil oral and topical together, or is it either or?
You can do both. So depending upon your customized evaluation, your dermatologist may prescribe or start out with one, both, or yeah. So we can do both topical and oral. We can start with just topical and go to oral. So it just depends on the appointment.
Agree.
All right, does anyone have any last minute questions? There's 10 more minutes left.
I saw that big long question. I can answer it. This person was describing that they use lots of oils and it seems to awaken the inflammation in her scalp. And so she can use some dilute rosemary oil. So when it comes to oils, I'm usually a recommender of using it on the hair as opposed to the scalp. And the reason is that I want my products, whatever prescription things I'm giving you, to actually be absorbed. So I recommend using less oil, or no oil to the scalp. There's a cultural sort of feeling that we need to put something to our scalps, grease or oil, pomade, etc. And part of that is because another condition that we really didn't talk about today is so prominent in people of color, and that's called seborrheic dermatitis or dandruff. And that is a very common disorder that may or may not accompany CCCA. I've actually looked at this, and we have a paper out that suggests that maybe seborrheic dermatitis or dandruff is a trigger for CCCA. We don't know. But if you have this flaky, itchy scalp, it may be some of that as opposed to all just CCCA. And in that case, sometimes oils can make it worse. So I recommend using the topical medications and oils to hair if you need them. And then that minimizes the number of people that I have to worry about getting irritated by the oils. And I treat seborrheic dermatitis with anti-dandruff shampoos and other modalities to get them under control, and more frequent hair washing. You know, the other thing that a lot of people do is they tell me, oh, I wash my hair once a month or every 6 weeks because that's when I change my hairstyle. And that actually really isn't enough. If you have a condition in your scalp, you need to wash your hair and your scalp more. Um, you know, like I said, my contract with my patients is every 2 weeks if they can do it. You know, if they have a special occasion and they can't, that's fine. But that's really what it should be.
Agreed.
What are your thoughts on MD Gashi's study in 2022 with his natural hair lotion?
I don't know that study.
I'm not familiar. Is that a what type of doctor is that?
Mhm. It didn't hit our radar, so I would say that's a no. I don't have a feeling about it.
They just said that he's a dermatologist.
Gashi.
Gosh.
I'll look it up.
What shampoos do you recommend for a CCCA?
So just an anti-seborrhea shampoo, and ketoconazole is a brand name that we use. We use low proc shampoo. There are a few that we can prescribe, but something that's really going to take care of the yeast. One of the things that we want, you know, if you're going to try something OTC over the counter, you want to make sure that that anti-dandruff shampoo just goes to the scalp, right? Some of them can be very drying and dry out the hair and cause breakage of the hair. And so I typically tell my patients to start out with applying the shampoo to the scalp like it's a lotion, right? Kind of rub it in there and then take some water on the balls of the fingers and just kind of massage it into the scalp, kind of leave it on for, you know, a few minutes or so. And then you can take your regular shampoo for your hair and kind of get the hair started with the lather and then rinse it out together. I find that to be less drying potentially on the hair itself. And we don't need to treat the hair with a seborrhea shampoo anyway. And then you can go on with the next steps in your traditional shampoo process.
Yeah, I'd say that's exactly what I do as well. So I looked up a couple of different spellings of Gashi. In my estimation, there's not been a true study. So this is you know, I'm just looking at time. So this is another thing, you know, I can get on my soapbox about a lot of different things. And one of those is when people say, well, I did research and what I like to first say is that I'm glad that you take uh, uh, you know, the tack that you want to figure out what's going on with you and you want to, you know, look up things and figure out what's going on. But you have to be sure that what you're doing is truly scientific and not just social media, because there's a lot more social media kinds of things out there that aren't true science. So they say we did a study and but it's not published in a peer-reviewed journal. Okay, when we publish articles and they're considered to be scientific, that means that they've gone into a peer-reviewed scientific journal, typically a dermatologic journal. So there are other dermatologists who have to review those papers and make sure that the science is real and that your outcomes and what you're talking about is true. When people put things on the internet and say, I did a study, and there's no publication attached to that, it can mean anything. It can mean I dreamt it last night and I decided to write about it. So you have to be careful when you know, talk about studies. So in my experience, this is not something that was studied. It's maybe something that somebody wants to sell. And when it comes to stuff that people want to sell, I'll tell you where they get you. They get you when it's weight loss, when it's about trying to get more money, aging, anti-aging, and hair. So you're going to get the most scams for those four things. So you have to be very, very careful that you don't believe it. For instance, four of my patients told me last week, and another one of my colleagues had this happen to her as well, that I was on TikTok talking about a miracle hair oil. Well, I can guarantee you, I don't go on TikTok. So that is not me. They actually lifted a real something that I taped actually in my medical center. And they put a voice under it, and they, basically have an actor that kind of makes it look like your mouth is moving and saying certain things. So these are lots of these things are scams. Like Oprah saying that she took gummies to lose weight. That's a scam. Don't believe it. Um, Stuff that you can eat chocolate cake 3 times a day and lose weight. That's also a scam. So don't believe these things. People seem very honest and they seem very earnest. I will say that, but they are not honest. So yeah, most of
The
these
same thing recently happened to Dr. Lindsay.
yeah, that's what I was talking
Right?
about. Yep,
Yeah.
exactly. So they'll try to get you any way they can.
Yeah. I
Right.
see menopause and perimenopause and inflammation and CCC. Just get ready. That journey can be very different for everyone. And I think just naturally can be a cause of hair thinning. Right. And so, we talked mainly about CCCA, but there can be, so many causes for hair thinning and hair loss. And that's why it's important to get a diagnosis, right? When you start to experience this, come in and see the dermatologist, and let's just kind of get this all out and get an idea of what could be going on. But it certainly can contribute to hair thinning and hair loss.
Mm-hmm. And you can have more than one thing. I have plenty of patients that have 1 or 2 or 3 diagnoses of different kinds of hair loss. So it's absolutely can't underscore how much it's important to listen to Dr. Mitchell when she says that.
All right. I believe the breakout rooms are soon going to end. But I just want to take the time to say thank you to Dr. Amy McMichael and Dr. Hope Mitchell for your time. You answered beautiful presentation and answered all of our questions, and it's greatly appreciated.
Thank
Thanks for
you.
having me.
Yeah, thanks for having us, and thanks, Dr. Mitchell, for pinch hitting in a very quick time. We appreciate that. And Camille, thank you for your help today.
Thank you.
Goodbye, everybody.
Bye, everyone.